We are pleased to be joined by Dr. Renee Armour, who is a breast oncologic surgeon at JFK Medical Center. Good to see you, doctor.
Nice to see you.
Can you help us, particularly the women out there who are a bit confused? The American Cancer Society has put out some new guidelines as it relates to when women should be having mammographies.
Correct.
Am I right that there's some confusion here?
Absolutely.
What is it?
It's that very reputable organizations are putting out different standards for guidelines for screening.
And by the way, there's the U.S. Preventive Services Task Force, and that is another organization.
Correct.
And they are not in sync with the American Cancer Society.
Correct. And
is it 40 or not?
And neither are in sync with American College of Obstetrics and Gynecology or American College of Radiology. So basically, I think what we've come to is it's not one size fits all. It's a discussion to be had. And the one thing with the patient, doctors and patients. So the one thing we want women to realize is all of the organizations say women should be given the option to start screening at 40. Nobody disputes the fact that death from cancer is decreased in patients 40 and above, regardless of the other risks of having screening, which we'll get into that. But all of them say, yes, death from breast cancer is decreased if you start screening at 40, and they all agree upon that. What they disagree upon is the weight of the other issues involved. People that are 40 to 45 tend to have denser breast tissue because they're younger. They tend to have more hormonally active breasts from perimenopausal hormone changes, estrogen surges, make cysts complex, simple, all kinds of findings on imaging.
Therefore, false positives?
False positives that can lead to biopsy. And biopsy is not completely benign.
Because we were just talking about this before we were going on the air, and no secret, but virtually every producer we have at the Caucus Educational Corporation is a woman. They think about this, talk about it all the time, and some of the women were saying, isn't it true that there is some research out there that says the more biopsies you have, there's a greater likelihood of
Correct.
breast cancer?
Correct.
And when I heard that, I said, that can't be right.
That is correct.
But how could that be, and what do you do with that information?
Right. So even breast tissue biopsies that are benign, or what we call low-risk lesions that don't increase your risk for breast cancer. There's certain things that they're biopsied, we know it increases your risk, atypical, lobular carcinoma in situ. There's certain things that, okay, this is your risk and this is how we screen and how we prevent it. And then there's things that are, this is nothing. Even those biopsies, if you have more than one, you're going to have an increased risk. It's actually part of the Gale model risk assessment tools, how many biopsies.
So what does a woman do?
You have to not over-biopsy. And that is the issue why certain boards, like the American Cancer Society, are now saying 40 to 45, really discuss it with them. Don't mandate that they have to do it.
Over 45?
40 to 45.
Over 45, then what?
Over 45, everybody, well, not true. American Cancer Society says every year, 45 to 55. American Cancer Society also says between 55 and above, every 2 years, because the cancers tend to be less aggressive and take longer to turn into something. There's going to be those that fall out of that norm.
And if I were to complicate things even more and ask the question, what impact does family history have on all of these situations, you would say?
So these guidelines, screening, are for average risk. So this is people without family history.
If someone's mother had breast cancer, does it change the dynamic?
Correct.
Does it change the... So now you're 40, you're 41.
Correct.
You have it.
Right. There's an increased risk associated. Now, most breast cancer is sporadic. Most people aren't going to fall into that category. So 80% of people diagnosed do not have a family history.
80%? No family history?
No family history, no genetic predisposition.
What percentage of those with family history do
go on to develop breast cancer?
Yes.
It depends, and a lot of it.
Other factors, risk factors.
One of the risk factors is how early the family member got breast cancer, how old they were. And these are risk factors whether or not they had it bilateral, a breast cancer on either side, and how many family members.
Does smoking matter?
Smoking,
Does diet matter?
Diet does matter for all cancer. Smoking, we used to think is not correlated to breast cancer. There's now research to indicate that smoking even can.
Can we give women out there right now any specific advice that they can take to the bank, to use that expression, diet? Anything you could say to them?
Yes.
Go.
Low fat, high fiber for everything.
Sugar?
Low sugar.
Okay.
Weight is more the issue with breast cancer. If you are above the normal BMI, you have an increased
Body
risk of
mass
breast
index?
cancer. Correct. Because
You have
estrogen
what?
breast
That's
cancers.
higher?
If you're higher than it, yeah. Yes.
And it increases your risk?
Right, correct. If you're above the recommended body mass index, you are at a higher risk for the estrogen-related breast cancers, which a vast majority of them are related to estrogen. Body fat turns into estrogen.
Woman goes to see her surgeon, her specialist. She should be asking what? After she hears this, she sees this interview. She asks what?
What is right for me? Okay, because every woman has the right to get mammogram at 40, and all of the guidelines say women should be given the option. So I don't want them to lose track of that and say, I can't get my mammogram at 40 anymore. It's not recommended.
And insurance and all this?
So far, it's not an issue.
Not an issue.
Not an issue.
At 40?
But it can start to become an issue.
It may.
Correct. I have not had patients thus far. The one little kink where a patient was coming to me saying that they didn't, it was an oversight on that part that they actually could have it done if it was prescribed.
So you understand women's confusion, but you're still saying talk to your physician, go through this,
Yes.
find out what's right for you. That's the best advice we can give right now.
Yes. But I can let you know, myself and everybody I know that as a physician still recommend 40.
You're going to do it right now. Say
Correct.
it. It's 40?
40.
No matter who says what.
It decreases your risk of death from breast cancer.
We'll leave it at that, doctor. I'm sorry, do you want to say something else?
Well, I think that's more important than the false positives.
Got it. Doctor, thank you so much.
You're welcome.
Complicated stuff, really important, and you help some people right now. Thanks
Thank you.
so much.
Thank you.
Stay with us. We're right back, right after this.
The preceding program has been a production of the Caucus Educational Corporation, celebrating over 25 years of broadcast excellence, and 13 for WNET, NJTV, and WHYY. Funding for this edition of Caucus New Jersey has been provided by Josh S. Weston, Investors Bank, Berkeley College, Suez, Delta Dental of New Jersey, Johnson & Johnson, and by the New Jersey Office of the Insurance Fraud Prosecutor. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area. Caucus New Jersey has been produced in partnership with TriStar Studios.